Welcome to video 3 of the lecture series, Applying Drug Evidence to Patient Care. In this video, we will be going over the meat of the presentation, the results and interpretation sections. In the previous videos, we looked at how guidelines select populations and then how they select evidence to choose from and how they select criteria from that evidence for which to assess, which then leads to their ultimate recommendations for clinicians in the broader population. In this video, we will be looking at scoring the quality of evidence, addressing uncertainties, and then in the next section, actually grading the evidence that goes into a clinical recommendation and guidelines. So let's start with the results. Scoring quality of evidence has to do with three main factors: the study design and conduct of the investigations that produce the evidence. So that's what we've been doing most of the semester. So what is the design of the study, and not only what is the design, but was the study conducted well? You could have a randomized controlled trial that is conducted poorly, and you can have observational studies that are conducted extremely well, that are stronger than their design alone would suggest. They can overcome some of the inherent biases within their designs if they're conducted well. So that has to be taken into account. The second factor that's taken into account is the relevance of the investigations to the target population. If you're looking at a guideline on hypertension, where the underlying study is conducted in a very similar population of hypertensive patients, and then we can look at coherence, which is the evidence supporting contributory cause and improvement in clinically important outcomes. It's more of a subjective measure, so does all of your evidence, when taken together, paint a picture of a causal relationship between the drug that was studied and the eventual outcome? Are you certain that there's a causal relationship, or are there other studies and maybe areas of evidence that haven't been uncovered yet that makes the overall picture murky and less coherent? We'll go into these things in a little bit more detail. The first is scoring the quality of evidence, and this should be the most familiar to you. Guideline developers assemble available investigations related to potential recommendations based on the underlying design of the study. Here's again our hierarchy of evidence. The quality of research evidence is based on the hierarchy of research types. Remember, meta-analyses of randomized controlled trials are typically the highest quality of evidence. In an individual study, randomized controlled trials are typically above cohort studies and case control studies, but again, you must read the study to assess the conduct. If a randomized controlled trial is done, but it's unclear how the authors randomize patients, and if the groups are very imbalanced at the end, then that will be scored lower than a randomized controlled trial that was well randomized, groups were well balanced, appropriately powered, and had large sample size. Those will be at the very top of our evidence chain. Again, cohort studies and case control studies are inherently of lower quality. However, if they're very well conducted and they reduce bias as much as possible, use appropriate sample size and power and the appropriate statistical methods to control for bias and confounding, then that might raise them above other observational studies or even above very poorly conducted randomized controlled trials. And again, down and down it goes until we're at expert opinion. Guideline writers also determine the degree to which key studies have what's called aggregate internal validity. So we're looking at studies which provide valid evidence for the population and the study in which it is conducted. We're looking at internal validity of all the studies and then the aggregate internal validity of our entire scope of evidence in making key recommendations for specific populations. Let's talk a little bit about relevance. So relevance needs to be evaluated for each piece of evidence which goes into the study. So are the types of patients studied and the methods used typically of the types of patients and methods that are encountered in your typical clinical practice in the population that you're studying? For example, are the studies, if you're looking at hypertension guidelines, are they assessing blood pressure in the manner that we assess blood pressure today? Are they using medications that are similar to the medications we use today? So relevance is the degree to which the intervention of interest has been investigated in groups or populations that are similar to the populations of interest. Whereas scoring the quality and conduct of evidence, we're looking at aggregate internal validity, how they're conducted. And with relevance, we're looking at aggregate external validity of all these studies that were conducted in similar settings and similar populations, so the ones that you see in daily practice. And then finally, coherence. Again, how does the evidence fit together as a whole? Are there major gaps in evidence that you'd like to see fleshed out before the picture is held together as a cohesive whole? And does the intervention actually improve important health outcomes? Are you looking at the right outcomes for your patients? Again, we're looking at objective, clinically meaningful outcomes instead of surrogate outcomes like we discussed earlier in class. So these three components taken together are used to score the quality of evidence for a particular disease state or particular interventions within that disease state. So again, that's study design and conduct, the relevance of the studies to your population, and the coherence of the overall studies. So has everything important been studied, and does the picture painted by the studies create a cohesive whole? If all are present, you can score the quality of evidence. Every guideline will score evidence a little bit differently. In this lecture, we'll talk about the USPSTF, or United States Preventative Services Task Force. They make a lot of recommendations for public health interventions at the population level. They grade evidence based on a system of good, fair, or poor. This is an example of what it would look like. So good quality recommendations are recommendations based on evidence that includes consistent results. And what that means is that a convincing case for effectiveness in practice can be made. Good quality evidence, they're highly confident, can be recommended by all clinicians so that they feel it will be effective in practice. Fair quality, again, the evidence is sufficient, but the strength of the evidence is limited. And again, in bold, what that means for the USPSTF is that no fatal flaws or holes are evident in evidence are present that invalidate a conclusion of effectiveness in practice. Then for poor quality evidence, we just have that evidence is insufficient and that there are major holes in the evidence that invalidate the conclusion of the studies. With that poor quality of evidence, then those will not go into making recommendations based on that other underlying evidence. In the hypertension guidelines, you can see that moderate quality evidence and high quality evidence are both present here in different sections. Again, I highly recommend that you read the guidelines to get a feel for how they're grading evidence and how that impacts the recommendations that are made in the guidelines. When you have all of the evidence together, there will usually be at least one small component of the guideline in which there are still uncertainties. In many cases, there will be a lot of uncertainties. So there is subjectivity involved in grading evidence, as we've seen throughout the semester. What I call a strong study and what you call a strong study might differ even if we're looking at the exact same criteria. So given that there's subjectivity, it's likely that there's going to be some uncertainties and some disagreements. There are formal and informal ways to address these uncertainties. Sometimes what are conducted are called sensitivity analyses, which are methods of addressing areas of evidence where there is some uncertainty. And this can involve new statistical analysis on a small portion of the data, which is murky or may involve masking value or subjective judgments about a particular area of uncertainty. This is confusing, and you won't be graded on it, but I just want to include it for completeness. An example would be the following. The net effectiveness of colonoscopy as a screening technique for colon cancer is believed to be dependent on the availability of skilled colonoscopists. Estimation of the number of skilled colonoscopists is not available, thus this is not considered an option that should be used for currently recommended in the population for general testing. In other words, if you have an intervention that is based on something in the population that's unknown, like how many people can perform a highly technical skill, or whether insurance companies will cover certain medication, then it's really hard to say whether you should recommend this intervention broadly, because there are certain pragmatic aspects of medical care that you just don't know. So you're unable to make a strong recommendation for or against something when you lack certainty about certain aspects of care. So that's how we score evidence and the results. Now we'll talk a little bit about how to interpret the evidence. So we've assessed quality of evidence, and now we need to actually make the recommendation. And what we're going to find is that it's not just based on the quality of the underlying evidence, it's based on the magnitude of the effect. If there's good quality evidence that has very low impact on population health, then we probably shouldn't be recommending something super broadly. Whereas if we have good quality evidence that something is highly beneficial, then we should probably be recommending those interventions more broadly to most of the patients we see with certain conditions. So this is going to be called scoring or grading interventions and evidence. Recommendations require, again, not just the rating of the quality of the evidence, the design, the coherence, and the relevance, but we also need to draw the magnitude of the impact of the interventions on our outcomes of interest. So we're not asking just does it work, but we're asking how well does it work. Magnitude can be classified in quantitative terms, and actually we've been doing it all semester with relative risks, odds ratios, means between groups. However, there's no strict rules on what is beneficial, so there is again some subjectivity here. So for instance, a relative risk of 2.0 might be really good for certain disease states, but not so good for other disease states, whereas a relative risk of 8.0 might be fantastic, and in that case you might want to apply to everyone, but this differs based on the field you're looking at and the guideline you're looking at. So again, going back to the USP-STF, they're scoring based on the magnitude of impact: substantial, moderate, small, 0, and negative. So you can have interventions, and there will be studies which show harm from certain interventions, in which case you would rate the magnitude as negative, as actively causing harm in the population. Let's look at how they did it in the hypertension guidelines. This isn't quite the same as the USP-STF scale, but it's similar. So these guidelines look at the benefit to risk ratio and then assign them different classes. So class recommendations are listed here, in which they're assessing the benefit of a potential recommendation which could broadly be implemented versus the risks inherent in that recommendation. So if you recommend a certain class of blood pressure medication that is highly effective, you expect the benefits to far outweigh the adverse effects that come along with that particular medication. You can see class 1 means that it is recommended, it's indicated effective and beneficial in the population of interest, and it's usually based on high quality evidence. But this class strength is based on benefit to risk ratio, not the underlying quality that we'll talk about in a second. So that was class recommendation. Then we have grading of the recommendation, which is based on both benefit and quality. So the overall net effectiveness of a recommendation is based on, and again, this is the USP-STF grading system from A, B, C, D, or I. And this is sort of like grading in classes where A is the best possible grade for a recommendation, meaning that the evidence is good, the benefit is substantial. So you can see in this table we have the impact of an intervention along the top, and we have quality of evidence along the side. As the quality of evidence goes up, your likelihood for a stronger grade of the recommendation goes up. As the impact of the intervention becomes more positive and more substantial, again, your graded recommendation also rises. I, for those who are wondering, stands for insufficient, and you can see all along the bottom row with the very poor quality of evidence, very poorly conducted studies. You cannot get a grade above I, which means insufficient. If you have a really poorly conducted study, we really shouldn't be drawing strong conclusions from it, and we shouldn't be grading recommendations based on that poor quality of evidence. This is a look at the grades for the strength of recommendations that the USP-STF uses. Again, I'll let you kind of dig into this on your own, but in general, you can see that their verbs change as the grading of recommendations goes down. So for grade A recommendations, strong evidence, substantial benefit, they strongly recommend those interventions. Grade B, they still strongly recommend, but the justification is based on good or fair evidence. For grade C, they're not making a recommendation for or against a specific intervention. Grade D, they're actively recommending against because there's no benefit and there's an act of harm. Then for insufficient, the evidence is so poor that no conclusions can be drawn. This is what it looks like in the hypertension guidelines. You can see that this is not quite grading. This is the level of quality of evidence. So this is part of what goes into the grading system. So level A is high quality of evidence from randomized controlled trials. B-R is moderate quality randomized controlled trials. B-NR, NR standing for non-randomized, is moderate quality evidence from observational studies. So if we go back 2 slides to see our quality of evidence score, this good, fair, poor here, this is how it was done in the hypertension guidelines, doing A through C instead of D or I. Whereas the benefit to risk ratio and class of recommendation would be similar to the grading recommendations here. Okay, so what I want you to take away from this lecture is knowing how evidence grading works based in both magnitude of benefit and quality of evidence. Know what goes into the quality of evidence rating and what goes into the grading system. Where would you consider ranking one study in relationship to another study if I gave you certain criteria like magnitude of benefit and quality of evidence? You don't have to memorize any tables, but just know how the generalities of how one recommendation would rank against another given the effectiveness of the underlying interventions and the underlying data quality. So this is the end of video 3. Thank you for your attention.